Hello everyone. So this next video is on case control studies, one of the analytical epidemiology studies. So case control studies are retrospective studies. This is something which students need to get absolutely clear in their head that other studies like cohort studies can be retrospective, prospective, retro plus prospective, etc. But as far as case control studies are concerned, they are retrospective studies, they are backward looking studies, and often they are the first approach to test the causal hypothesis because they are part of analytical epidemiology. We are testing the causal hypothesis. By causal hypothesis we means a hypothesis whether, say, a factor A is related with a disease B, whether it is related, whether it is not related, if related, how much related. That test is done using analytical epidemiology, and generally the first approach as a part of the analytical epidemiology are case control studies. Now, case control studies, as the name suggests, will have two groups. One is cases, and we mean by cases those participants who have the disease. Which disease? The disease after which we are looking for. The disease which is in consideration in that particular study. And the other group would be controls. So, controls, in general sense, it may mean to stop, but in epidemiological sense, control basically means a comparison group. So at many places you would hear this word control. For example, a cross-sectional study may have a control group. In a randomized control trial, there will be a control group. But in case control study, there has to be a control group because the name suggests there are two groups. One is cases, one is controls. And also another characteristic is that the unit of this study is individual. That is, we don't compare group A with group B. One case is actually compared against one or two or multiple controls. We are not comparing group of individuals against multiple groups or a single group. We are comparing an individual against one or more individuals. That is one case against one or more controls. Now, there are three distinct features of case control studies. And first and most remarkable thing that both exposure and outcome have already occurred. As I already said in the first slide, and to repeat it, this is a backward looking study or a retrospective study. Disease हो गया है, exposure हो गया है. The question is whether that disease and whether that exposure are they related, and if related, how much, how likely are the questions. So both have already happened. Study proceeds backwards, and that means study proceeds from effect to cause. In technical terms, the word backwards can be referred to as a retrospective study, or in other words, we are looking from effect to cause. The effect has already happened. We are trying to find out whether the cause may be related or not. And this study is going to use a control group or a comparison group for sure. As I said, control here does not mean to stop, but it means having a comparison group. Very important to understand this basic 2 by 2 table if we have to understand case control study. It is important anyways for understanding most of epidemiological studies, but yes, definitely important in understanding case control studies. So in this 2 by 2 table, we basically have these two columns of cases and controls. Now you must be knowing columns means the vertical ones. The vertical ones are known as columns. The horizontal ones are known as rows. These are rows, and these top to bottom are columns. So in columns, we have two cases and controls. Cases are those which have the disease. Controls are those where obviously the disease is absent. And in rows, we have the suspected factor or the risk factor, or many a times it is referred to as exposure. And the row heading is exposure present and exposure absent. So generally or invariably, this first cell is labeled as A. The second cell, that is the top row right cell, is labeled as B. The third cell is labeled as C, and the bottom row right cell is labeled as D. Also prudent to understand that this sum A plus C is basically the total of column which represented cases, and that means it is the number of individuals having the disease. See, the column header says disease present, and this A plus C is the total of that column. Okay. Similarly, the column controls will have its total P plus D. That is, these are the total number of individuals included in the study who do not have the disease. The disease is absent. So very, very important to understand this 2 by 2 table. If you want, you can go back few seconds and listen to this again. Don't move ahead without making this crystal clear in your brain. Moving ahead, what are the steps of case control study? There are 4 steps. The first step is selection of cases and controls. The second step is something known as matching. What is it? We will see in detail. The third step is measurement of exposure. And the fourth step is that you analyze the data that is collected and you interpret the results. Select cases and controls, match them, measure the exposure, and analyze and interpret the results obtained. We will go over these steps one by one. First, and perhaps the first most important or the most important step is selection of cases and controls. Selection of cases is relatively easy. Now, when we mean relatively easy in comparison to controls. Cases are whom जिनको disease है, those who are suffering from disease. So a case of breast cancer or a case of myocardial infarction or a case of seal-like limb has to be found out. Where will we get this case? Either we will get it from hospital or either we will get it from some hospital network or from some hospital registry. So that is relatively easy. Selection of matched control with no or minimal confounder present. What is confounder? We will see in few bit. Is but this selection of match control with no or minimal confounder is the difficult part, because you just don't want control, you want control who is matched as per the various characteristics, and preferably there are no confounders, or at least there are as minimal confounders as possible. So that makes a selection of controls difficult. What is matching, what is confounding factor, that we will see in few minutes. Going on to cases. Now, selection of cases may be easy, but the crucial step or the difficult step, the technical step, perhaps the most important step of this whole setup is that you define the case properly. You have to define the case very, very meticulously. If that definition is not correct, it will impact who is selected as a case and who is not. It will impact the results, it will impact the analysis, and thereby the interpretation. The diagnostic criteria which you are going to use has to be specified and has to be specified in crystal clear terms. So you cannot say breast cancer. You have to say which stage of breast cancer and how are you going to consider the diagnosis of that breast cancer. Are you going to use mammography? Are you going to use MRI? Are you going to just use self-examination, or are you going to use combination of all these? Has to be crystal clear in this definition of cases. Mammography, MRI, etc. were examples related to breast cancer. Cases can be anything, whatever is the disease in consideration are the people having that disease are cases, but the definition of who is having a case or who is having that disease has to be very clear. And then we look for eligibility criteria. So generally, the common dictum is that you take the incident cases. Now, what is incidence, what is prevalence is for another video. But when we say incident cases, we mean new cases. And when we say prevalent cases, we generally mean the cases which are already existing. So for case control study, the general dictum is we take incident cases. Then source of cases, where you would get these deceased participants. So you can ideally get them in a hospital, or if not hospital, you can get them in a general population. Now, how would you know in a general population who is having a particular disease, who has had a cancer, who has had a myocardial infarction, who has had a genetic defect? So these hospitals may be having some kind of network and you may get the address and the contact details of that particular deceased participant whom you want to enroll, or there may be something known as the registry, is a video in itself to be made some day later. But yeah, for now, you can remember hospital networks or registries can give us the contact details, the location of deceased individuals in general population who can be in turn used or enrolled as cases for our case control study. Moving forward, now we are looking after the controls. This is the single most important line that needs to be understood, that needs to be remembered. Cases, disease present. But obviously, if you want to have a comparison group, which is the control group, you have to have them free from disease. Now, it's one thing saying free from disease, but then there are something known as a subclinical form. So for example, in all the various examples that you would see on case control studies, regarding case control studies in this video or in the subsequent videos or in our textbooks or even over the internet, most of them would be on diseases like cancers. Now, cancers do have subclinical forms. There can be a breast nodule which would tomorrow go on to develop a grade 1 or grade 2 or stage 1 or stage 2 breast cancer. But today, taking that particular female as a control may actually affect the validity. But how do you know which female is going to have that cancer tomorrow is very, very difficult. Another example I gave of myocardial infarction. So now people have angina. Angina and myocardial infarction are basically clinical forms of the same disease, which is the coronary artery disease. So can we say that angina pectoris is a subclinical form or a preclinical form or a previous stage of myocardial infarction? Very much so. And then there can be individuals who would be having coronary artery disease and would be having absolutely no symptom at all. So the message is that saying that we don't want subclinical forms is very easy, but to actually practice this while conducting a case control study, it's very, very, very difficult. Similarly difficult is this step. Finalize the controls before the study is done. That means you finalize from where are you going to take controls, how many controls, and preferably who are the controls. Ideally, that consideration, all those steps should be done even before the study is started. But again, ideally and easily said, difficult to be done. The next consideration is how many controls. So if sample size is large, then you can go for 1:1. But if you have small sample in your case control study, small sample, by that we mean sample less than 50. When I say sample, I mean cases less than 50. Then we can go for 1:2, 1:3, or 1:4. Now, very important to understand what does this ratio mean. Now, 1:1 obviously should not be a problem. But when we say 1:4, then more often than not, this would mean that one case and four control. In fact, I would say in epidemiological considerations, wherever you see a ratio, unless proven otherwise, the smaller number, which is invariably 1, we are talking about the diseased population or the cases, and the larger number, which may be 1, 2, 3, 4, 10, 15, 20, whatever, is the controls or the comparison group. Please remember that. Very, very important to remember that. Now, selection of appropriate control group affects the validity of inferences. What do we mean by appropriate is coming very soon. Before going to what is appropriate, we should first look at this statement which says cases and controls must be comparable. In an epidemiological study, we do not want to compare, as an old English proverb goes, apples with oranges. We want to compare apples against apples, oranges against oranges, males against males, elderly against elderly, females against females, truck drivers against truck drivers, masons against masons, and so on. Again, very easy to say that in an academic context, very difficult to actually practice it in a research context. But yes, we should remember, at least in theory, that cases and controls must be comparable. You cannot compare let us say males having myocardial infarction who are also smokers against females who are smokers. Now, it is a known fact that males have, being a male is an independent risk factor for developing myocardial infarction. So this kind of a case control study, whatever odds ratio and whatever result you get, it will not be very valid. Next, moving on to sources of controls. So sources of controls can be hospitals, firstly, that is, you can enroll the patients of other diseases, or you can enroll patients from another ward, patients admitted for other reasons, patients who are visiting that hospital on that particular day for some other diagnostic workup or anything. What is very important is we said in the beginning that the case has to be defined very, very clearly. Now, invariably, when you define a case, and when especially the definition includes a stage of cancer or even something like a myocardial infarction, now this is not something which is diagnosed or which is ascertained clinically. The patient has to undergo a diagnostic test to be ascertained as having breast cancer of a particular stage, a particular grade. The various classifications that are used in oncology, all those come are as a result of various diagnostic tests. Ideally, in an ideal case control study, your controls should also undergo the same amount of diagnostic workup. And this is, again, you would understand, this is extraordinarily difficult. So, for example, suppose your case control study is on myocardial infarction. Now, myocardial infarction, generally what we call as the STEMI, ST elevation MI, is diagnosed on ECG changes. But nowadays, even the measurement of enzymes is very important in diagnosis of myocardial infarction. So your control should also undergo, by control, I hope we understand now, the subjects who are kept as comparison group, all those should also undergo the same ECG procedure. And if you are using enzymes to diagnose and detect and define the myocardial infarction, by enzymes I mean troponin T, troponin M, etc., then your control should also undergo the same troponin and other enzyme diagnostic tests to be defined as free from disease. This is very difficult for getting estimation of cardiac enzymes. You have to give your blood. Now, someone who is admitted for say an cough and cold in your hospital, and you want to you want to uh, use him or her as a control against a MI patient, he would obviously object. Why should I give my blood for heart related investigations where I have nothing even close to that disease? So, practically speaking, saying that control should be comparable to the case is one thing, but actually getting that becomes very, very difficult. And thereby, there are selection biases of different kinds. What are bias? What are selection bias? That would be covered in the second part of this video. Coming back, if hospital patients or other patients of the same hospital are not available or are not feasible or are not ready to give consent, then the relatives of that same patient can become controls, or neighborhood people living in the neighborhood can become controls, or we can directly go into general population and look for an individual of same age, same gender, preferably same occupation status, etc. Now, I said the same age, gender, occupational status, etc. And that is what is known as matching, which is the second step of our case control study. So controls will have different socio-demographic as well as medical characteristics. By medical characteristics, I mean the past medical history includes both the diseases as well as the medications and the treatment taken. So choosing of controls that are similar to cases with respect to all these characteristics is basically what is known as matching. So if this is a case and if this is a control, these two individuals should be same to each other in all aspects except for that this particular individual is having the disease and this particular individual is not having the disease. This process of getting an individual who is preferably of same age, same gender, same ethnicity, same religion, same occupation, same past medical history, same economic status, and so on. This process is known as matching. So we are trying to prevent what I mentioned few minutes ago. We are trying to prevent comparison of apples against oranges. Then in matching, there is this important concept of confounding factors. Theoretically, confounding factors are those which are distributed unequally in study and control group. What does this mean? Distributed unequally का मतलब ये है कि इसमें या तो ज्यादा, इसमें या तो ज्यादा. So that means they are not matched. They are not similar in this particular respect. Another way of saying it is that these are factors which are associated both with exposure as well as disease. Now, one typical example given is, suppose we are looking in a case control study where the disease under consideration is esophageal cancer. The exposure under consideration is alcohol. So we take two groups. One is having esophageal cancer, one is not having esophageal cancer. And we are looking for the alcohol consumption as the exposure, and we are looking how much of alcohol, how many having uh, alcohol consumption, and how many had the disease, etc. So in that, a factor like smoking can be said to be a confounder. So why smoking is a confounder? Smoking in itself is a risk factor for esophageal cancer, and it is obviously not a rule, but if we look at the social prevalence of smoking and alcohol, those who consume alcohol are pretty likely to be consuming cigarettes, that is, to be smoking cigarettes as well. So, thereby, smoking can be said to be scientifically related to the disease in consideration, that is, esophageal cancer, and smoking can be said to be socially related to the exposure in consideration, which is alcohol. So, that is how a confounder works. So, this confounder can be removed by matching. So, in an ideal world, you want cases of esophageal cancer who may or be having alcohol exposure, controls who may or may not be having alcohol exposure, and both of these groups not to have this confounding factor. This is the most important concept that you need to remember. The confounding factor should ideally be absent, because we don't know how much and how is the relationship between cancer and smoking and cancer and alcohol. So that's why ideally we want that confounding factor not to be there altogether in our study setup. Easier said than done. Now, then there is something known as overmatching. Suppose someone is attending a class, looking at a video like this, and immediately tomorrow you are setting up a case control study. So you would say, नहीं वो sir ने बोला था match करना है, confounder हटाना है. I'll match everything. I'll remove all confounders. Are there problems in there? Yes, there are problems in that also. So what firstly may happen that the suspected etiological factor may also get matched. So if you are looking at a cancer, let us say breast cancer in women who use oral contraceptive pills, and if you take controls also who are using oral contraceptive pills, then your exposure is also getting matched. In this case, you may still get some kind of association between the OC pills and the cancer of the breast, but your odds ratio will get reduce. That is, you will underestimate the risk that the OC pills present of having breast cancer. Risk of having breast cancer amongst OC pill users may get underestimated because you have overmatched. And all said and done, the most important thing is it would be very difficult to find control. So, for example, you have a case of breast cancer who was born in January 1980. She has had two children in her lifetime, and she has completely breastfed both the children. And now she used say OC pills for 10 years, and she has developed breast cancer. Now you have enrolled her in your study. Now ideally you are looking for a female born in January 1980, preferably having identical or close to identical height and weight, of same religion, occupation, and economic status. Then you are looking that control woman should also have had two children. She should have also completely breastfed both her babies. And as I said in the first part of this slide, she should have used the OC pills also for 10 years. and then you want to enroll her, it is very difficult to get this kind of situation in actual practical real world in research setting. So these are the three threats of overmatching. Then we go to the third step, which is a measurement of exposure. Now, before we measure exposure, we already said definition of case was very important. The definition of exposure is equally important, if not more. मतलब क्या है? You define who is a case. Case मतलब who is having disease. Similarly, when you are looking at exposure, how much of exposure you want to consider as significant is also very important. So you cannot just say smoking. You have to say smoking up to 5 cigarettes a day. It may be any number of cigarettes a day. This is just an example for at least past 10 years or more. 10 years or more is okay. But you cannot say smoking 5 cigarettes a day. Someone might have started last month. Obviously, the chances of cancer in him would be much less than someone who is smoking only 5 cigarettes, but smoking since 40 years. So, your exposure has to be also defined in appropriate terms. And this definition is also as equally important as the definition of cases. Now, information which you require for this study, it has to be obtained from cases and controls. So how you can obtain it? You can conduct interviews of those cases and controls across a table, or if it is an admitted patient, bedside interviews. You can give them questionnaires. The difference between interviews and questionnaires invariably is this: interview is conducted by a researcher or his associate or someone from the study team, and questionnaires are something that we more or less same question, but it would be given to the study subject or a relative or someone who is accompanying the subject, and they would be asked to fill the questionnaire. So, but obviously the questionnaire should be in the language and in the wordings that the study subject, the patient, would be able to understand. Thirdly, you can take information from medical records. So, logically speaking, suppose a cancer patient gets admitted, his or her diagnostic criteria, the results of that diagnosis, the other medical histories, the other treatments, even his socio-demographic factors like age, gender, etc., would already be recorded. So, if you want to record these findings, you can easily take them from medical records, and whatever else you want, you can use either of these two to get that information. This way, your process of collecting the data would become time efficient. In other words, we can use combination of these 2 or 3 techniques to get your data for the analysis in this case control study setup. Finally, moving on to the fourth step of case control study, which is analysis. Now, unfortunately, analysis of case control study, or for that matter, for some students, case control study is equals to odds ratio. उनको ऐसा लगता है केस कंट्रोल स्टडी में ऑड्स रेशियो के अलावा कुछ है ही नहीं, या केस कंट्रोल स्टडी के एनालिसिस में ऑड्स रेशियो के अलावा कुछ है ही नहीं, which is not the fact. We have already seen, I am talking for last 15-20 minutes about case control studies, and this is the first time I have brought the wording odds ratio, and that too I have brought it to make it very clear that analysis of case control study is not equal to odds ratio. Yes, odds ratio is one important or one of the most important consideration of interpretation and inference from a case control study, but that is not equivalent to the procedure of case control study. Okay. So first part of analysis of case control study is exposure rate. Now, what are the exposure rates? So going to our standard A, B, C, D table. Now I have not written here is that the disease would be here and the risk factor would be in the rows. Disease present, disease absent, risk factor present, and risk factor absent. Now these exposure rates are also known as frequency of exposure, or they are also known as frequency rates. Now these two terms, frequency of exposure or frequency rate, are both from our standard textbook, that is Sparks textbook of preventive and social medicine. So you have to know that, you cannot bypass that exposure rates are also known as frequency of exposure, or in other word, frequency rate. Now exposure is calculated separately for a case and separately for a control. So exposure of case is A upon A plus C. This is the A cell, and A plus C, as I told you, would be the total of cases that have been enrolled. I said that few slides ago. Similarly, exposure for control would be B upon B plus D, where B plus D is obviously the total number of controls enrolled in your case control study. Now, moving forward, you need to compare these two. You get some result from step 1, that is A upon A plus C, and some result from step 2, that is B upon B plus D. How would you do that? So for that, if this is a discrete data and you are getting percentages, then chi-square test can be used. And if this is a continuous data like blood pressure, which are obviously rare occurrences, but suppose you manage to set up a study where you are measuring blood pressures and you are using the means of blood pressures, then there is something known as standard error of mean, which can be used to compare these two exposure rates. So very important to remember, analysis of case control study not equal to odds ratio. Before calculating odds ratio, there is something known as exposure rate also known as frequency of exposure or frequency rate. We calculate exposure for case A upon A plus C. We calculate exposure for control B upon B plus D, and we compare both these exposures using tests of significance like chi-square test and others. Moving ahead, there is something known as estimation of risk. Now, this is again very important to know that ideally whenever we want to estimate risk, we want to calculate a relative risk. And relative risk, which would become covered in cohort studies in detail, relative risk by definition is the ratio of incidence among exposed upon incidence among non-exposed. It is the ratio of these two incidences. Now, what is the problem in case control study is that we don't have incidence. And why we don't have incidence? Because the denominator is unknown. We are not considering the whole population. We are only taking say 50 cases, and even if it is a 1:4 study, then 200 controls. Now I hope you understand the meaning of the terminology 1:4. One case is to 4 controls. That is why I said 50 cases, 200 controls. So even if you are taking 50 cases and 200 controls, you are not considering the population as a whole, and that is why you don't have a denominator to calculate the incidence of that particular disease. Because you cannot calculate the incidence, you cannot calculate incidence in exposed, you cannot calculate incidence in not exposed. This numerator you don't have, this denominator you don't have, and thereby this relative risk we cannot have. And because this relative risk we cannot have, that is why we go for something similar, something close, which is known as the odds ratio. And there comes the favorite wording with respect to case control studies, the odds ratio. So odds ratio, as I already said, is closely related to relative risk. It is used to measure the strength of association. स्ट्रेंथ ऑफ एसोसिएशन का मतलब क्या? स्मोकिंग से लंग कैंसर होता है, पर चांस कितना है, लाइकलीनेस कितनी है? दैट इन एपिडेमियोलॉजिकल टर्म्स or in technical terms we call as strength of association. And in case control studies, strength of association is given by odds ratio. But before moving to the formula of odds ratio, there are these 3 assumptions that we need to understand very, very particularly. Firstly, the disease investigated must be relatively rare. The cases which you have taken must be representative of those with disease. Now, by representation, it is again the same thing. Lung cancer, in general, what are the ages, genders, occupational groups, economic status in which it happens? So the cases enrolled in your study should ideally have closer ages, similar genders, similar occupational status, and other similar characteristics. And similarly, the controls which you have taken should also be representative of those amongst general population who do not have the disease. So with these 3 assumptions and with the background knowledge as to why we cannot calculate relative risk, and with another background knowledge that odds ratio is used to measure strength of association in our case control studies, we move to the favorite formula. Odds ratio, a student's favorite measure. Odds ratios formula, favorite formula. So again, before we go to formula, this standard table, cases in columns, cases and controls in columns, risk factor present and absent in rows, the standard A, B, C, D. So the odds ratio is given by A upon B whole divided by C upon D. You do some mathematical rearranging and you will get that this odds ratio is equals to A into D whole upon B into C. Now, if you see here, we are multiplying A against D and we are multiplying B against C. And because we are like doing a cross multiplication, that is why this ratio, multiplication in other words, is known as product. So this ratio is also known as cross product ratio. A into D whole upon B into C. Finally, if we get an odds ratio of 8, what does that mean? So odds ratio of 8 means the disease is 8 times more likely. Whenever you are answering anything about odds ratio, be it a Viva question, be it a spot question, be it a uh, a theory question, or even for your concept sake, you have to understand that you need to use this word more likely, or at least for that matter, likely when you are using odds ratio. कितने times, कितना likely, strength of association. Don't forget those words. So we are measuring strength of association, and in talking terms or in writing terms, that strength of association is, uh, you know, summarized with this word likely. So odds ratio of 8 means disease is 8 times more likely in those having exposure as compared to those without exposure. So let us take an example of lung cancer and smoking. Smoking, we are say considering less than 5 cigarettes over past 10 years. So and we calculate the odds ratio after collecting the data and doing the analysis, and let us say the odds ratio comes out to be 8. So our inference would be the chances of lung cancer among smokers who smoke up to 5 cigarettes a day for past 10 years or more, the chances are 8 times more likely as compared to those who do not smoke. Okay, so that word more likely, which is the literal way of using the measurement of strength of association, is very important whenever you are talking about odds ratio. So the story so far in this tale of case control studies, in this topic of case control studies, we have looked after the definition of case control study, the two groups, what does control mean, why it is difficult to get a control as compared to getting a case. We have tried to understand what are the standard terminologies in a 2 by 2 table that we draw for most epidemiological studies, but particularly we have tried to understand in context of case control studies. And further, we have seen the 4 basic steps of case control study, which are: firstly, you select cases and controls. Secondly, you do matching. As part of matching, you try to remove confounding factors, prevent overmatching. Thirdly, we measure the exposure, record the data. Fourthly, we do analysis. Analysis would include measurement of the exposure rate, beg your pardon, calculation of exposure rate, also known as frequency of exposure, also known as frequency rate. And then the exposure of case is compared against exposure of control using tests of significance like chi-square test. Another analysis that we do is we calculate the odds ratio, also known as the case cross product ratio, one of the important measure that we get from case control studies, and we measure strength of association using odds ratio. In literal terms, it is written by using the words more likely, chances of having, or chances of getting, chances of being, etc. So these are the salient features of case control study, at least whatever we have studied till now. We will continue this in a second part. Till then, thank you so much for watching the video. Have a nice day. Bye bye.